From my side, no problem.
So, good evening and welcome all for today's session of eGurukul. Today we are having a case presentation and discussion. With this discussion, our mentor, our guide will guide us how to go and to reach to the diagnosis. But the journey is always better with when the guide is there with us. So, as our AOPG president, Dr. Jhankhana madam, is there in another meeting, I, Dr. Nehal Patel, Secretary AOPG, welcome you all. I also welcome Dr. Sandeep Trivedi, our West Zone Vice President. He is always there, as Sir mentioned. In eGurukul, he don't leave us single day not to be there. And I welcome Dr. Lata, who is Chief Coordinator here. Our expert, Dr. Nitin Rao, is joining shortly in 5 to 10 minutes as he's just reaching the home. So, handing over to Lata for further proceedings.
Good evening, everyone. Thank you, Nehal ma'am, for always with kind words. So today we are going to have a very interesting case presentation. Who presenter for today is Dr. Aditi Dubey, who is a third-year resident at GCS Medical College. Her mentor is Dr. Vrajna Parikh, who is assistant professor at the same institute. And expert for today is Dr. Nitin Rao, sir, who is pediatric cardiologist at Star Hospital, Hyderabad. Of course, we have with us the great, our own Dr. Baldev, sir, who is always there, whatever be the scenario, but he's there and he's mentoring everyone, each of us, even with faculties also. So I think if Nehal ma'am permits, we can start the case presentation. Ma'am?
Yeah, thank you. और सफर का मजा मंजिल से ज्यादा अच्छा होता है. That is how हमें सर पूरा सफर कराते हैं for each and every case presentation. Sir, the platform is all yours.
Good evening, friends.
Yeah,
Welcome
Nitin sir
this
joined. Sir, Nitin
Is
sir
it-
joined.
Sorry?
Nitin sir, our
Nitin, sir.
expert.
Okay, fine.
Good evening. Sorry, I couldn't join early. I'm so sorry.
No, it's
sir.
not like
Good evening, sir.
Dr. Nitin Rao, you are in time. You are not late.
Thank you.
Nice to see you.
Nice to see you, sir. Good evening, sir.
Good evening, friends.
Good evening,
Welcome to
sir.
this our PG clinic. As already informed, Dr. Aditi is a presenter. She is from GCS Medical College, Ahmedabad. I request particularly the students, those who are on the screen, that please keep your video on and participate in the discussion.
Yeah.
I will say participation should be in such a way that Aditi should find the difficulty to answer. Some of the queries, questions, and I think that can be raised by only her colleagues.
Yeah.
I request all the students, please, our flow of the discussion will remain in such a way that first Dr. Aditi will start the history part. We'll take this many times for the expert, it will be very superficial, but still we'll go for the basic pediatrics. And from the basics, we'll go to the advanced. And when we are stuck up or the last word, we'll take from Dr. Nitin. So I think that will be our flow of the discussion for our information. And with this remark, I request Dr. Aditi to share her PPT and start the history part.
Right, sir.
Good evening to all the faculties, my seniors, colleagues, and juniors who have joined this session. I thank Gurukul Pathshala for this opportunity for presenting this case. I'm Dr. Aditi, third year resident Medical College. I'm presenting a case of a 11-year, 2-month-old girl from Ajmer, Rajasthan, belonging to lower socioeconomic class according to modified Kukuswami classification, presented with the chief complaints of easy fatigability and breathlessness on increased activity for 4 months. Child was asymptomatic before 4 months, after which she developed easy fatigability while doing household chores like mopping and washing utensils and playing with peers, which is gradual in onset and slowly progressive. Child gets tired earlier than peers of the same age during physical activities such as running, climbing stairs, and prolonged walking. Fatigue is more noticeable with exertion and improves with rest. According to parents, child requires frequent breaks while playing or doing school physical activities. Over the past 4 months, she developed breathlessness on exertion, which is gradually progressive. Child gets breathless on performing exertional activities like climbing stairs and brisk walking, and slowly feeling breathless even on performing routine activities. Child is comfortable at rest and there is no discomfort with change in posture, and there is no diurnal variation for the complaint.
Okay, I think Aditi, can you stop sharing for a while?
Yes, sir.
Let us try to understand the symptoms what she has described. Who will take the initiation? I want the volunteer participation. Anybody? Aditi, you can find out if somebody known to you, which if I'm not knowing. I know all students from GCS, but I think they are not there. And some other places, I think teachers can help so that we can identify. And please, I will say, come forward by your own. I think Dr. Aishwarya, probably I know. Dr. Aishwarya, are you there?
Aishwarya, please respond.
Lata, anybody you know that so that you can motivate them, they can start to.
Any other PG is also okay. We've got 40 people on board. Any PG is okay.
I think Dr. Shivani. Shivani is from probably GCS. Same, Aditi?
Yeah. No, Shivani is from my institute, sir.
Okay, okay. So I think she can start it. I think what she described here, 11 years female has presented. And two symptoms she described in details. One is easy fatigability and breathlessness. Let us take one by one. I will say easy fatigability, 4 months duration. What do you mean by the easy fatigability? Suppose if you are sitting in the OPD, patient enters with these complaints, easy fatigability, how you will take it? How will go for further, I will say, data collection, gathering the information, and then how will you try to analyze so that at least you understand that what is the likely problem for the fatigability or what you mean by the fatigability, what the patient complains. I think Aditi, you can start it, and meanwhile others will join. Suppose simply at present we will not be biased with the case which probably everything you must be knowing. Just you are sitting in the OPD and mother complains, and I think this is very common complaints many a times. That my child is getting fatigability, feels generalized weakness, something like that they talk. How will you take it? How will you interpret? What other questions or points you will ask and gather the information from which you understand that what is the likely issue with the child?
So, sir, if a child presents with easy fatigability, that means, sir, he's while doing the routine activities or while any exertional activity, if the child complains that he's tired and sits for a while or takes breaks. So we have to firstly ask about, sir, nutritional history, because that is very common in Indian scenario, and multivitamin deficiencies and iron deficiencies can cause this kind of presentation, sir. So we have to ask about the nutrition of the child first.
Okay.
And iron deficiency.
Anything else?
Sir, if there are
anything else, I think always try to think just in a normal flow. Many times I think you must be complaining, Aditi, that today there were many patients, heavy emergency. At the end of day, you say that I'm fatigued. Right. Many times all of us are complaining like this. Particularly in this season even, just even due to the even heat also, and if you are really exposed for even the short time, without anything, we feel that I'm fatigued, I'm weak. Right. And then how you take it. That's why what was my point, that if any patient complains, try to understand, then what my question will be there. Is it today only or even for the long time? So that I understand that what is its importance. And what we understand here, weakness or fatigue, that means lack of energy. We will take in that perspective first. And lack of energy can be due to several reasons. Lack of energy really due to this exertion, which probably have taken for some exercise, some work, or you have not got rest or something like that. Or even sometimes really fasting, observing for some time, then also lack of energy. As you are describing very rightly, that anemia, and that anemia naturally of even the longer duration, initially just they will complain of this fatigability or not feeling well or weakness, something like that. Sometimes it can be due to lot many issues, even due to electrolytes problems also. Just they will complain of this fatigability. Even the fluid loss, improper perfusion, right, hypoxemia. In all the conditions, just they may have the complaint of fatigability, of lack of energy or tiredness. Different, I will say, terminologies they'll be using. But what we mean, that this problem due to the several reasons. And then what is the duration? And what is the progress? That will give you the gradually idea that what is the likely reason and how we should take it. I think coming back to now our patient, what you said, fatigue, you said 4 months back, child was asymptomatic. Aditi, are you sure? Absolutely asymptomatic? No complaint and suddenly sharply started 4 months back?
Yes, sir. According to the relatives, she had no complaints before 4 months. And after that, slowly she is developing this fatigability and breathlessness on exertion.
Right. So I think very, very rightly she said, and 4 months duration, we understand that it's not this so acute. Right. So we can take in that perspective that some condition, whatever it is, making the child gradually the fatigue and going on, even probably as you describe it, is progressive in nature, fatigability. So now coming back to even the breathlessness. Let me go to Dr. Shivani. Yes, sir. Dr. Nitin, you wanted to say something.
I just want to interrupt. See, Aditi, you have said fatigability and then you say breathlessness.
Right.
What sir has said is absolutely correct. But you have to be very clear because you imply two different things. Fatigue is not, breathlessness is different. They imply two different things, especially when you talk of CVS. There are a lot of the causes, but when you come to cardiovascular, you have two different interpretations. You have to be very careful. You are saying both are there. First came fatigue and then breathlessness. What came first? Did both come together?
That's why even for demarcation, first I discussed that focus only on the fatigability.
Exactly.
Now we are coming to the point of breathlessness.
Yeah.
Then we'll try to even discuss whether both are same or different, in what way you are interpreting.
Yeah.
And then with this interpretation, what importance you will give.
Exactly.
So I think what already we discussed is only fatigability. Now
Right.
let me go to Dr. Shivani. Shivani's second complaint, what Dr. Aditi has described, is the breathlessness. I hope you were present when she described.
Yes.
Did you listen to her?
Yes, sir.
Okay, so you know the details. That initially, and 11 years old girl, so she herself can even describe the problem. Probably whatever the mother has observed, she will add, but we can even discuss or directly you can have the conversation with the patient herself. And probably according to her, initially there was some breathlessness. Gradually she described very nicely that with some activity it was there. And then gradually or with this some routine activity or daily probably what she was helping her mother in mopping out, doing some household activities, she was observing the problem. Somehow at the last she added that still she was comfortable on rest, not having much problem of breathlessness. Am I right, Dr. Aditi? And therefore now, how you will interpret, Dr. Shivani, this complaint? How you will analyze?
Gradually increasing deterioration of problem that leads to her to increase in a breathlessness even at the rest due to failure, any worsening of the condition.
Anyway, simply if I ask the question, very simple question, not confusing to you. Well, how in what perspective you are taking? Is it likely due to some respiratory cause, cardiac cause, or something else? What is your interpretation? Because all of us know that breathlessness can be due to several reasons. Commonly two. Either there's some respiratory cause or some related to cardiovascular system. Now, from this description, what is your perception? How you are taking that likely respiratory cause or cardiac cause?
Cardiac cause.
And whatever we say, we'll have to give the explanation. That's why you are taking it the cardiac and not the respiratory. On the contrary, I will say that being the general pediatrician, for me, respiratory causes are more. So I will take that this is the respiratory problem. Because presence of Nitin Rao does not indicate that it's a cardiovascular problem.
Okay.
Probably besides cardiology is interested in general pediatrics also.
Definitely.
Therefore,
pediatric first.
So Dr. Shivani, what was my idea that how will you explain?
Breathlessness due to respiratory causes associated with symptoms of respiratory distress like tachypnea and use of accessory muscles, nasal flaring, and not comfortable.
It depends upon severity. May not be in all the patients. It depends upon the severity. Suppose if it is a mild one, may not be having this, I will say, all these indrawings and even the nasal flaring and head bobbing and these things may not be there.
Duration and progression of the disease.
Okay. How will you try to interpret it? How does it help you?
She's having breathlessness and easy fatigability over the period of 2 to 3 months and gradually increasing.
Okay. I think Dr. Sri Harshini, she is putting on the chat box. Somehow I wish that she should be vocal. But still, you know how we can try to differentiate. Number one, most of the times in respiratory causes, respiratory conditions, they have some other system problems or complaints related to the respiratory system. Isolated only breathlessness, probably very few. Yes, it can be, but most of the times having some other associated respiratory symptoms or indicating some infection, like there may be the cough, very common, I think, which may take the bronchial asthma, may not be fever, but yes, cough is there, breathlessness is there, right? Suppose pneumonia, then fever will be there, cough will be there, breathlessness will be there, right? Or even suppose some pleural effusion or pleural, some pathologic condition, then at least there may be some chest pain or something we are expecting. And second thing, all these conditions are mostly the acute in nature. right? Most of it, may not be all. And therefore, it will not be the going on in this way of 4 months. Second thing, usually whatever the problem is there, that it is not going to be the 4 months and progressive in this nature. Most of the respiratory conditions. Of course, some conditions like bronchiectasis, cystic fibrosis, some recurrent immunodeficiency disorder, yes, even they can present of longer duration, but commonly, then again, they will have some other manifestations also. Having this, probably we can consider that likely this cardiac problem or breathlessness due to the cardiac condition. Then I think very important question which commonly they are going to ask you, because I will keep in mind always the exam also, not only the practitioners. Then they will ask you the question that what are the different gradings of dyspnea and breathlessness? Whether dyspnea and breathlessness are same or different. Let me take the help of Janmejai, because now he's not the student, but I will say junior consultant. So whether the terminology, most of the times we are use interchangeable. That breathlessness, dyspnea, difficulty in breathing, right? Shortness of breath, various points we use. What exactly we mean by all these different, I will say, terminologies?
Sir, by and large, we consider dyspnea as breathlessness, but dyspnea we commonly use in relation to cardiac pathology.
Why? Very distinctive feature for the respiratory and cardiac, breathlessness or difficulty in breathing is going to remain even in the resting phase, also in the respiratory cause. There may be some change in the severity, but it is going to remain. While dyspnea, what we call it actually exactly exertional dyspnea. That means with the exertion, some degree of dyspnea increases. That means, heart has to work. And when the heart has to work more, there is this difficulty in breathing. That classically we call it the dyspnea on exertion. And that indicates probably cardiac cause. So you know how we are using the terminology, and therefore the breathlessness probably is the generalized terminology, which may be in a case of bronchial asthma, maybe in a case of pneumonia, maybe even in a cardiac cause, even maybe in a case of metabolic acidosis. Because all the conditions we say most of the times difficulty in breathing or breathlessness. But once you go in the details of it, that specifically on exertion, it is precipitating or severity increases. That means probably it is related to the cardiac problem, related to the heart. And therefore we understand that dyspnea. And then the question comes of grading. Dr. Shivani, can you tell that how we grade this dyspnea?
Yes, sir.
Grade this dyspnea?
NYHA classification, 4 grades are there. Dyspnea on exertion, dyspnea on climbing stairs or for few steps, and dyspnea on walking and routine activity, and dyspnea even at rest.
I think I know Dr. Vivek was there last time also. Dr. Vivek, can you take it? How will you grade this dyspnea? And nice to see you again. I remember you that you were also quite interactive in the last session. Am I right? Dr. Vivek, unmute yourself. You are muted. Unmute. Yes.
Yes, sir. Sir, according to NYHA classification, and this patient is
Sorry, which classification you name?
NYHA classification.
What is that?
New York Heart Association,
Yeah.
sir.
So it's a good thing even to note it.
Yes, sir.
Various some
when the patient is doing more than ordinary effort, then is having breathlessness, and that is known as grade 1. So if the patient is doing ordinary effort, then this is in grade 2. And if it's doing less than ordinary effort, then it is grade 3. And patient is having dyspnea at rest, then it is grade 4, sir.
One thing you should always say, whenever it's very strict definition, you should say patient with heart disease. Then you start getting all that word has to come. Patient with heart
Yes.
disease. All right, because
Patient with
everyone
heart
goes
disease.
yeah. Then you start.
Yes.
Absolutely. I think very easy to remember. This is given the way described in the books, but how we can understand or translate in this, I will say, when we are talking to the patient. Usually how they complain, suppose the adult patient, they will say, sir, I was walking for 4 kilometers, 5 kilometers daily since many years. I was not finding the difficulty. Yes, if I have to climb some stairs or even some hill station or some temple, I may become the breathless. That means it is the unaccustomed exercise. Now 4 kilometers or 5 kilometers, the person who is daily walking since, I will say, long time, now becoming breathless, that is unusual. That means he is breathless with even the accustomed exercise. Further, even he said, then I stopped to walk. They were talking this way. Then I stopped to walk. I was comfortable for some time. But again, with even daily activity, even in my house, when I'm moving around from one room to another or even up and down, I'm finding the difficulty. That means grade has increased. Even once he says that even to take the bath is also now I would say strenuous for me. That means the still it is progressing. And says that even when I'm sitting in the chair and reading the newspaper, still my respiration is going on more. That indicates, and even sometimes the patient may complain that I'm comfortable during the daytime, but I immediate after a few hours of going to bed, I have to get up, I have to sit, or I have to go to the window, and then I get some comfortable. That is orthopnea. That in the sitting posture or some posture. So, and that very classically, if you listen to the patient, you understand that it is the classical dyspnea, increasing with the different, I will say, limitations, and even at rest gradually, that means it is the progressive. That gives a very classical reason that whatever this is the typical description of the cardiac condition. And that means the heart is gradually finding difficulty in pumping. That you can predict that this myocardium is now not having the same efficiency which it was. I will say not just I will go for the classification or something. Ultimately, we understand that what's the problem with the child. And that gives the idea. May not be obvious, I will say, all classical signs of cardiac failure in every patient. This may be sufficient for the physician to understand initially, to go for evaluation, to locate the cause, and even whatever the required, it is a medicine or the management should be started. So I think that's the thing. Now, if you go for the summation of fatigability, and as Dr. Nitin was describing, that fatigability can be even due to any cardiac or anything. Just even as I said, that exertion, exhausted, or even due to energy lack, due to some hypoglycemia, anemia, due to so many reasons. But now with this fatigability and breathlessness together, very classically it gives that this patient is not having any respiratory cause, any other system, or any other factor responsible just for the lack of energy, but classically likely the cardiac problem. And even we can add that likely this gradually myocardial function is getting compromised, right? That's the thing that how I think before we go further, let us take a word from Dr. Nitin as an expert, and then we'll go for further information. Dr. Nitin, please.
Yeah, what you say is very correct only. But one thing I want to say is that once Can you see me?
Yes, yes.
Yeah.
You're audible.
Yeah. So what happens is one thing is fatigability is different thing, breathless is different thing. We from a cardiac viewpoint, fatigability is where one very is because of low cardiac output. So so usually it is right heart disease. Something like tricuspid valve disease or pulmonary right heart disease is fatigability.
Absolutely.
And dyspnea is usually left sided. When
Yeah,
the pulmonary congestion. So when you say dyspnea, orthopnea usually mean elevated LV, EDP, LA pressure. So that's what happens. So your first symptom came of fatigability. That's a good thing. So usually we imply when you say fatigability is something like right-handed tricuspid stenosis or severe TR. And when you say dyspnea is usually left side events, that's the implication. Okay?
absolutely.
Yeah. And then because how old is the child?
11 years, 2 months.
Slightly on the older side.
Yeah.
Right.
But you know why, Aditi, I will say sorry asking the age. Suppose if it is probably, even I would also like to go for that. Suppose it's a only infant. Infant is not going to complain all the ways. Right. Then what will be the presentation in an infant? Problem may be the same. But then what will be the presentation in infant? Let Shivani, I think, answer because she is there. Because I want to involve the multiple students. Shivani, when you can call your some other colleagues also, so that you can also get some relief in between. Right.
In
Suppose
infant,
some infant is there with a similar some cardiac complaint, how infant will present or what mother will observe, and she will make the complaint. That's the thing which I wanted.
difficulty in feeding,
Very good.
suck cycle, and perspiration during feeding are the complaints of mother in case of infants.
Very good. I will appreciate her. I think Dr. Sri Harshini, I'm not sure whether she is there on the screen because she is putting on the chat box.
Yeah, she's
Maybe
not
her
on
choice.
the seriously, you can join.
Yeah, I think better to join. Very nicely she is putting. You know, many times mother will just complain of difficulty in feeding. May not be able to describe. Even she will say, not taking feeds properly. And once you ask in the details, probably she will come out. Every mother may not be able to observe very appropriately. Very simply, she will say that now takes some more time in completion of it.
What do you mean by suck cycle?
Yeah, what is the suck rest cycle and why it happens so? That sucking, taking the rest, sucking, why it happens so? Explain it. That's a point what sir wants. Shivani, can you explain?
During the sucking, oxygen demand increases, so child gets tired and taking rest for the meet up for oxygen demand, and then again sucking.
Why does this happen? What is the pathology underlying? There's some amount of pulmonary edema, there's some amount of bronchioles are flooded. That's the whole thing. That's what happened. And then the child starts feeding again. Alright? So this is always left side events. Interpretation left side events. Right? Now one question for Shivani and Aditi. We talked of NYHA classification of all that. Now, can you apply to infant, a 10-year-old child? Fine. Infant, what will do? Is there any other system?
Yeah, I think this classification may not be applicable today. That's the point, sir, want that. Is there any other way of classification for the infants?
Based on feeding.
Like NYHA, is there any other system you are aware of?
MRC classification.
No. It is called CCS, Canadian Cardiovascular Score. That's applicable for. Just look up. This is your homework. CCS, Canadian Cardiovascular Score. Because the regular NYHA can't be applied to infant, apply for older children, right?
Yes.
Yeah. All right.
So I think these are the points which we should be aware of it. Please remember some of the points even from the exam point of view. Once you say prolonged feeding, how much prolonged? Please remember more than 30 minutes also. And Socrates cycle, yes, sir, asked the question, going to be the very common, that why it happens so. Very appropriately, Shivani explained that it happens, and very rightly when sir explained that what is the heat, I will say basic pathophysiology for Socrates cycle. That means what sided heart is involved. That also you can predict for this from this complaint. So these are the points. And excessive sweating, again we know that there is the increased sympathetic or activity, right? Due to that, there is the perspiration over the forehead. Somebody will ask us why it happens more on the forehead and not other places. If you are having the good scoring, then the question is going to be continued. Why it happens? Yes, Shivani?
It is easy to observe on forehead.
Is it? But mother will say, I have observed other places also. Because mother is as competent as Dr. Shivani. And it happens so that particularly it is over the forehead. Please remember, it's an anatomy physiology. These sweat glands are in excess in the infants over the scalp and forehead. Therefore, this perspiration commonly they observe over this part. And if you remember, it's a fact that the sweat glands are more over this part. Anyway, but these are the things that how there may be the discussion will take place. Aditi, I think you can take it further. We have discussed only probably the first slide.
Negative history. There is no history of cyanosis, no history of chest pain, no history of recurrent respiratory infections, no history of facial pedal edema or facial puffiness, no history of sore throat and joint pain, no history of palpitations and syncope, no history of vomiting, headache, seizures or focal neurological deficits, no history of fever with chills, bluish to purplish bleeding spots on skin, and no history of caries tooth or any dental interventions.
Again, can you stop sharing, Aditi?
Why did you ask chest pain? Why did you ask chest pain?
Yeah, let I will say Dr. Nitin take this point. Sir, you can take that. What is the why she has gathered all the information for negative points?
Yeah. Why do you ask chest pain?
Sir, there are some cardiac causes for chest pain in pediatric population. Sir, like mitral valve prolapse or aortic stenosis and alcapa. So mitral valve prolapse is very common in females. So, sir, we can ask about that.
All right. Very unlikely, yeah, this there. But now, what is the what was directing towards? What are the cardinal symptoms? NYHA. What will you ask? One is breathless. Second, what are the four symptoms of NYHA? One is breathlessness. Second is chest pain. Third, syncope, palpitation. These are the. This is cardinal. NYHA, four things: chest pain, breathlessness, syncope, and palpitation. All right. All right. So what are the symptoms you asked? History of. What are your negative histories?
Sir, no history of chest pain, no history of syncope and palpitations. Sir.
Anyway, I think I have taken the photograph so that I can add one by one. One is the cyanosis, what she's saying.
Yes.
So what was the importance of cyanosis, Aditi, in this patient? What you wanted to
Sir, cyanosis will divert towards cyanotic congenital heart diseases. So we have to.
Which cyanotic congenital heart disease will present at 11 years? Which congenital heart disease? Because I will ask you the relevant to my patient. And if it is, you can give the explanation. Eisenmenger syndrome, what Dr. Harshini has mentioned. But how Eisenmenger syndrome will present? Straight away cyanosis? Anyway, number one. Second, chest pains are asked. Then Aditi had mentioned recurrent respiratory infections. Shivani, what is your idea? Why Aditi has mentioned?
Cyanosis, sir?
No, recurrent respiratory infection.
Recurrent respiratory infection in increases rate of recurrent respiratory infection in pulmonary edema. In cases of pulmonary edema due to
ultimately what she, I will say, wants to derive from this information in our case. Always your attempt should be, your goal should be this. That presence or absence of these respiratory infections, how it will help you.
What do you mean by recurrent respiratory infection? Is there a definition?
Yeah.
more than 2 episodes in 1 year or more than 3 episodes of any time.
That is for pneumonia or for some other condition. Recurrent pneumonia or some other.
Recurrent pneumonia.
It is for recurrent pneumonia.
Is sinusitis also recurrent RTA?
More than six respiratory infections in a year which require hospitalization, oxygenation.
Or IV antibiotics.
Yes. Right. So I think here that means any pulmonary congestion commonly left to right shunt. Again, probably may not be, but suppose in the past it was a different story. Pedal edema and facial puffiness, already probably part of the cardiac failure. Sore throat, joint pain. Shivani, quite obvious. What is the importance of sore throat and the joint pain in this patient?
Rheumatic heart disease.
Yeah, and I think it is relevant. Looking at the age, right? We should ask, okay, palpitation, syncope, already sir clarified. Then the vomiting, headache, seizures. Vomiting, headache, seizures, or focal neurological deficit.
See, Shivani, what you said is correct from a rheumatic point of view. But when the presenting symptoms are breathlessness and fatigability, then rheumatic is to complete the list, yes. But it should come almost at the last because the history wise is fatigability and breathlessness, that's for sure. She's very sure about that. All right? So,
yes, sir.
Anyway, this to complete the list, yes, agreed. Then Aditi, you asked for neurodeficit, right?
Sir, the chronic hypoxemic states will cause polycythemia, plethora. So, child is predisposed to stroke-like events and cerebral venous thrombosis. So, that is more common in cyanotic congenital heart diseases.
Is there any age group?
Sir, it is more common in around 2 to 3 years of age. Sir.
And then?
2 to 3 years of age.
Oh, less than two. Why is that so?
Sir, because cyanotic congenital heart diseases like TOF and they present around 6 months of age. And the cyanotic spells are common between 6 months to 2 years of age.
Yeah. So therefore, this with thrombosis and polycythemia viscosity occur less than 2 years of age because children less than 2 years of age are prone to dehydration. They get loose motion, and then they cannot take care of themselves hydration. Older child may take care of hydration themselves. Therefore, these thrombotic effects are common in less than 2. What happens after 2?
Even here, I think with the same question, reference to Dr. Nitin's question, somebody is going to ask you that what you describe cyanotic spell, Aditi said it's common 6 months to 2 years. Why that specific age? As sir explained, why it disappears after 2 years? That means it's not common, it is decreasing. We may not be total disappear, but it will be decreasing and less common or may disappear later age. Why it happens so?
Sir, the body develops polycythemia and homeostasis for this chronic hypoxemic state.
Any other idea, Janmejay?
Sir, by increasing the age, the respiratory receptors in brain get sensitized over the time, and so the trigger will be less in advanced age. And sir, second thought is developing of collaterals gradually.
I think multiple reasons. One point was Nitin sir said, you know that younger the children, mainly the precipitating factors, they are not able to avoid, like the dehydration, polycythemia, different reasons, right? And very specifically, you know, that 6 months to 2 years, that is not the mature system. Particularly, even the, you know, it is the dynamic. And with the dynamic, I will say changes, there is a precipitation. Probably by 2 years, as Janmay just said, it is matured and lesser the, I will say, effect of the dynamic situation on these receptors. And even possibly, probably collateral has also started. And due to these multiple factors, these are the explanations that this is very classical age for the cyanotic spell. And somebody is going to ask you, I will say details which we did in the last time, the OSCE, how will you manage the cyanotic spell, the classical management and everything. But that I think the negative point what you have mentioned is right. Then you said caries of tooth and dental interventions. Then fever with chills, bluish purple, bleeding spots. Aditi, what is your idea of all these points?
Infective endocarditis can have such histories.
Okay. You know, again, please keep in mind for the negative histories, 3 aspects should be included. Points related to your patient, that presence or absence of that particular point, which help you to, I will say, come to the diagnosis, which supports or even tries to exclude. Second group of the points should be selected related to your case, where probably nearby differential diagnosis you can make it clear. And third group of the points, where in that particular condition probably some known complication. Now you want to define whether these complications are present or not. As Aditi has mentioned over here, cyanotic spell, CNS involvement, or even this bacterial endocarditis. That means these complications may develop in this particular cardiac condition. That she wants to verify that yes, these complications are absent. At least no signs and symptoms of this complication. If you keep in mind, I will say in any patient, please don't go for the very lengthy list which is given in the standard textbooks. Keep in mind that out of all the points, select pertaining to your case. Then it becomes, I will say, impressive history, and definitely it becomes, I will say, very concise, right? So you can take it further.
Past history. Child was admitted for complaint of high-grade fever and cough at 9 months of age at a private hospital in Rajasthan, where on clinical examination, physician suspected a congenital heart disease and was advised echocardiography for the same and was referred to a specialist. As per mother, cardiologist advised surgery, but they refused. Child has grown up well following that, without any significant history of hospitalizations, ICU care, and need of oxygenation. There is no history of cyanotic spells, squatting, or squatting equivalent episodes in the early childhood.
What are squatting equivalents?
Sir, the typical squatting position is knee chest position, but squatting equivalents are crossing of legs or just sitting position in an
lying prone.
Yes.
I said, now see this. You said the history is very clear. 9 months of age, and there was some suspicion. Advised surgery, and mother refused. Now, sometime back, Dr. Sriyashini said this could be. When we asked, she said this is possibly Eisenmenger. Do you think this is Eisenmenger?
Dr. Aditi, you have any other point with reference to this past history?
No, sir.
Then I think you can stop sharing so that we can make this point clear. Yes. Now respond to sir's question.
Could this be? Could this be Eisenmenger? Sometime back to Sriyashini, I said this could be Eisenmenger. Could this be Eisenmenger syndrome? Diagnosis at 9 months of age, advice surgery, parents refuse, and now it's Eisenmenger.
Sir, in the Eisenmengerization, sir, there is from acyanotic,
Yeah.
then there is suddenly there is cyanosis developing. So
Yeah.
this child never had cyanotic episodes, not in
Never.
childhood, not presently. So never had cyanotic episodes. So Eisenmengerization.
The other thing is, the other thing, if the child was diagnosed at 9 months of age, and they will not become Eisenmenger 11 years of age without any symptoms. The child was doing very well, right? No recurrent infections, no hospitalization, unlikely.
No.
See, rarely some Eisenmengers may have elevated fever from the beginning, so they never have, but it's very rare. Very fact that 9 months to 11 years baby is relatively okay without any symptoms is unlikely to Eisenmenger on history-wise. It could still be, but history-wise it does not fit. All right?
Aditi, my question will be very simple. Have any patient presents to you with a cardiac condition? How will you try to differentiate? Is it congenital or acquired? Clinically, how will you try to differentiate? That there is a, this will be the possibility, may not be always right. But commonly, how will you try to differentiate that this is more suggesting congenital and this is highly suggesting acquired?
So, sir, first the age of presentation.
Okay. Can you give, with every point, give the example?
So, if the child presents in the neonate at birth in the first week of life, so we will suspect duct-dependent lesions. So, it is a congenital heart disease. Then, if the child presents at 4 to 6 weeks with failure to thrive,
I think very simple. Make it, I will say, very precise answer. That younger the age, likely the congenital heart
more
disease.
likely the congenital heart disease.
Particularly neonates, infants, toddlers, most of the time they are congenital heart disease. Older the age, usually after the age of 5 or so, more likely it is acquired. From the age, usually we try to differentiate in this way. Okay, second point.
Sir, then we have to look for growth parameters. If the child is failure to thrive, if the child is having feeding difficulties, and
after certain age, Aditi, probably that point may not help. Younger the age, okay, but very specific for congenital and acquired. Growth may be probably any chronic cardiac condition will going to affect. Presence of cyanosis. Please make it very strong point. Suppose if you are sure there is a cyanosis, most probably congenital. Right, very strong point. So like others. One more question I will say. Can you give some examples? Even the younger the children can develop the acquired heart disease. It's a cardiac condition, but acquired. Even the younger age group, because already you said younger the age group congenital. Most of the time, right.
Sir, Kawasaki disease patients.
Very good.
Can cause this.
That's the point. On the contrary, now acquired heart disease, Kawasaki is coming up. I will say crossing over this rheumatic. That's why I purposefully asked the question. Even suppose the very young, 6 months, 9 months child, myocarditis can occur, viral myocarditis. These are the acquired causes. Even post-diphtheritic cardiomyopathy, they come even younger the age group, but it is acquired. It's not congenital.
Endocarditis.
Yeah, but can you give some example that even the older children or adults, they present with a congenital heart disease?
Sir,
now it is a older adolescent or even the adults, cardiac condition is detected, but it is congenital.
Yeah,
defect can.
Yes, okay. Aditi?
Sir, ASD can present in adolescent.
Okay, ASD.
One is ASD. Second, anything else?
Mitral valve prolapse, MVP with symptoms.
Okay. Significant. It's basically structural, I will say. It should create the problem, but somehow it does.
Hypertrophic obstructive cardio.
Hypertrophic obstructive cardiomyopathy usually transient and disappears even before it creates any problem in the infant of diabetic mother. Right. But you know, very
HCL may become symptomatic later also.
Yeah, even anomalous pulmonary venous rate are different varieties. Even I will say that abstain anomaly is known to present with the severity of the newborn with cyanosis arrhythmia may die even before you understand. Two, even the mild, even the adult, just nothing incidentally X-rays taken and showing the cardiomegaly turns out to be even the right atrial hypertrophy and it's an abstain. So abstain is very wide way, I will say, spectrum of the presentation.
Yeah, Aditi, anything else has bimodal presentation. Abstain is bimodal. One is neural, one any other disease has bimodal presentation. One is either infancy and one is adulthood. Tell me.
Sir, VSDs, sometimes VSD.
Not bimodal, that's not bimodal. Bimodal, definition of bimodal is either one peak in infancy, one peak in adulthood. One is abstinence, already done. Next.
It's like that.
Either present in neonatal period with heart failure or in adulthood with hypertension. I'm giving the clue. Coarctation of aorta.
Coarctation can present. Similarly, if I ask the question, Shivani, let me ask Janmajay. I know that Janmajay knows the answer. Purposefully I'm asking. Janmajay, are you there?
Very much.
Anyway, Shivani, then you are getting the opportunity. What is the most common congenital heart disease?
ASD.
That is the most common answer and most common wrong answer.
Wrong.
It is the most common answer. Vivek has also mentioned VSD. And for that reason, I will ask the definition of congenital heart disease. Who will define? What is the definition of congenital heart disease? Then answer the second question. What is the congenital heart disease? Then many points where what we discuss will be very clear in your mind if you are knowing the exact definition.
Comment off.
Aditi, you can try. No problem. May not be all the points, but I'm sure that you'll be able to make the attempt.
Sir, according to NADA's criteria, sir, major criteria.
that is the criteria, but definition is different. When you are in dilemma, you are not sure, then follow the NADA's criteria to label it in the cardiac condition. It is not for congenital. It is for cardiac condition. But congenital heart disease is a condition where it may be the structural, functional, or positional. It may be structural, functional, or positional. Regencies congenital means from the birth, which may manifest, which may not manifest at all, but still it is present. That means congenital heart disease may be the structural, may be the functional. Functional, that means particularly from the electrophysiology point of view, conduction point of view. Positional, dextrocardia, levocardia, mesocardia, any positional may not, and every cardiac condition may not manifest, may manifest in childhood, may manifest later on in the adulthood, may not manifest at all. You don't know. But presence is since birth, since the stage of the embryogenesis. Now answer the question, congenital heart disease, which is not manifesting, but it is present since birth, and it is the most common. That means its manifestation is not there common.
Yes.
And that is the bicuspid aortic valve.
Oh.
Bicuspid aortic valve is most common. Many times we don't know. You may get on postmortem. Person died due to road accident. And so it was the bicuspid aortic valve. Sometimes may manifest even after this infection as the aortic incompetence. But it is the most common. And if you are knowing this definition, congenital acquired early presentation, late presentation, not presentation, everything you can answer. Anyway, I think that was a good discussion generated by Aditi from her presentation. Aditi, now you can complete because already we have taken more than 1 hour. So you can complete, I will say, history part.
Family history. This is the pedigree chart. Child is third by birth order, born out of third degree consanguineous marriage. There is no history of similar illness in the grandparents, parents, and siblings, and there is no history of chronic illness in the family.
Janmejay. Mother was having the congenital heart disease. She was operated. She is now fine. Is there any tendency for her offsprings in incidence point of view?
Yes, sir. If parent has a heart disease, then offspring tend to have more than 10% of likelihoodness, sir.
Probably Dr. Sriharshini is doing something in cardiology. I'm sure maybe the fellowship or maybe the super specialty. Sriharshini has mentioned, right? The common incidence is less than 1% probably, if I'm not doing the mistake. 0.8 or 1, right? And that increases to, please, even among these parents also, with the mother, incidence increases, it is more than 10%. And with the father, incidence increases, but it is less, probably around 5% or so. But this point should be known, and you know that VSD support, mother was operated, but still, her offspring can have the more chances of congenital heart disease compared to general population. That we should do.
Father and one sibling are the same.
Yeah.
Father and one sibling.
Yeah. Okay. Aditi.
Birth history. Antenatal history was uneventful. TD vaccination was given in the second trimester. Iron folic acid supplementation was provided. There is no history of fever with rash in any trimester. No history of drug and radiation exposure. 2 USG scans were done in the second and third trimester, which were informed to be normal, for which no documentation is available. No significant medical history and comorbidities in mother.
I think for the lack of time, we don't stop everywhere, but every place questions are going to be asked you. Maternal illnesses, maternal infection, maternal some diseases like diabetes, on even the other comorbid conditions, how it can affect the baby from the cardiac point of view, that we should know, Aditi. Just to give the idea, you can go ahead.
Child was born at term gestation, 39 weeks, normal vaginal delivery with birth weight of 2.8 kgs, cried immediately at birth and did not require NICU admission. No documentation is available regarding vitals at birth. Baby was started on breastfeeding on first day of life. No history of bluish discoloration of lips, nail beds or mucosa after birth. No history of suck-rest suck cycle. There is no documentation regarding SpO2 of the baby in postnatal.
Anyway, Janmati, I think before I forget, I will ask the question. Routinely, not to miss these cardiac some conditions, in the postnatal ward, before you discharge the baby, what specifically points should be examined, undocumented in your discharge summary? Cardiac point of view. Cardiac point of view.
Sir, bilateral femoral pulses.
Okay, one is the femoral pulsations.
And second is preductal and postductal SpO2.
That how will you do?
One probe at right upper limb and second at left lower limb or right lower limb. But ideally, we should examine all 4 limbs, sir.
Okay, how will you interpret it? Suppose somebody has done.
Sir, if difference is more than 4 to 5, then it is significant, and we have to rule out cardiac pathology.
I think Dr. Nitin will make the point clear. Dr. Nitin, can you guide us that in every baby before discharge, what we should do on document on the paper not to miss the cardiac? Please, you unmute yourself. Dr. Nitin, you are muted. Unmute yourself.
Saturation now, I recommend to see in 3 limbs, both upper limbs and 1 lower limb.
Yeah.
Not minimum 3, ideally 4. Because you can have anomalous supplementary arteries also, you can miss out something. It's always recommend 3 limbs, 2 upper limbs and 1 lower limb. Alright? And that is not what you said 10 years back, it was not there. But now it is recommended for all should be done. In fact, the amount of conditions you can pick up with bedside SpO2 is tremendous. You can always do that. It is recommended to all. You should do it. Yeah.
Then what is the difference in these readings which we can give the importance?
More than 5%. More than 5%. Yeah. There are some reports of 3, but we take as 5. That's all.
And nowadays, I will say this is not only for the academic or our point of view, but legal point of view, we'll have to do it. Because nowadays, people give the importance that it's a primary duty of the pediatrician to do this type of the screening test before you discharge the baby. So many other tests are there clinically, but cardiac point of view will restrict. Okay, Aditi, can you take it further?
Yes. Developmental history. Child has achieved all age-appropriate milestones and studies in standard 6th with good scholastic performance. However, child is unable to participate in strenuous sports activities. Child is immunized up to 10 years of age according to National Immunization Schedule. However, no documents are available. BCG mark is present on the left arm.
Why child is unable to participate? Because of again fatigue. This is what it is.
Yes, sir. Dyspnea on exertion. The child has.
All right. Okay then.
Diet history. Child consumes 1690 kilocalories per day, has a caloric deficit of 6%, and consumes 38 grams protein per day, and has a protein deficit of 13%. My analysis according to history. An 11-year-old girl presenting with exertional dyspnea and easy fatigability without any history of cyanotic episodes or any recurrent respiratory infections, and normal growth according to relatives, likely suggestive of a acyanotic congenital heart disease with normal or decreased pulmonary blood flow, likely mild obstructive variety, without signs of congestive cardiac failure.
My question is, why not is rheumatic? It is likely rheumatic problem, rheumatic heart disease. Because the child had never this, I will say, complaint suggesting congenital heart disease. And 11 years old presented this since last 4 months. Yeah. So what I understand that likely this rheumatic, may not be necessary fever, sore throat, joint pain, may not be there, may not be noticed. You may not get the history. And probably now with this established mitral stenosis, probably child has presented very classically this type of story. So to me, it's a rheumatic heart disease. There is no question of congenital heart disease.
Aditi, tell me, answer Aditi.
Sir, as I've already mentioned in my past history about that congenital heart disease, so
that may not be present. I will say what you said. Somebody inform and advise them, and may not.
When does the symptom start? When does the symptom start?
Yeah, may not be necessary.
Sir, before 4 months, sir, for rheumatic carditis, there should be some evidence of streptococcal infection.
Not necessarily but nobody will notice it. Every patient, not necessarily they will go for ASO titer, documentation, even may not be arthritis. But now fortunately, you don't get this many patients of rheumatic. We used to see several patients, I will say rheumatic in a month, I will say. And during that time, significant number of the patient, you may not get the history of sore throat, you may not get the history of the arthritis, that typically admitted for carditis and now has come, straight away patient will come to you with established rheumatic heart disease. Mitral stenosis was very common. Right. So I will remember that this is the story which I have learned in the past. So to me, this is rheumatic heart disease. There is no question of congenital heart disease. And if you wish, then you will have to convince me. Aditi should be able to convince me. I made my argument. That's why I don't consider. I'm trying to convince you. Now you try to convince me.
Sir, according to the age group, rheumatic is common in this age group, 5 to 15 years age group.
It
When did
must have
symptoms
developed after
start?
5 years.
When did your symptoms start?
It must have developed after 5 years.
Before 4 months, the symptoms have started.
What symptoms? What symptoms?
Sir, exertional dyspnea and fatiguability.
Okay. Fatiguability before 4 months is very unusual to interpret. Yeah, SOB breathless. Okay. And then and then they were told at what age? 9 months.
9 months. Yes.
See, rheumatic fever, it could, like Sir said, it could still be there, but such an early onset is very unlikely. But still, you never know. You can never, at 11 years, you can never discount rheumatic fever. But what you should say is from the way it started, unlikely. You cannot say no, unlikely, right? In our country, rheumatic has to be there, but the very fact it's coming from 4 months of age, so it's unlikely, possibly. Okay?
Yes.
I think, Aditi, you can ask me the same question which I ask you.
Yeah, why not?
You should ask me the same question. Suppose you can say that I am not able to answer, or I tried my best to convince you, but now you answer me the same question which you asked. I would say the student should do like this. Even Dr. Nitin should find the difficulty being cardiologist. That unfortunately I was present. He should feel like this. then I think all of us can learn. That what is my idea, that all of us can learn. You can say, I will say straight away cannot be ruled out, as I said, rheumatic heart disease. But I will say it is the quite, I will say, less possible. The reason is, you can say that, the rheumatic disease itself has gone down now. Not so common seen in the practice. Second thing, there is no classical presentation which is known or having some evidence, some idea, some point suggesting rheumatic in the past. Nothing is there. With this, even the disease going down, I will not consider as the possibility in the, I will say, upfront. Of course, even totally I cannot rule it out, but I will keep it at the bottom. And by chance, if it turns out to be rheumatic, maybe the surprise to me. You can answer in this way, nothing is wrong. And in the medicine, totally cannot be ruled out, but certainly I think you can put your possibility in this.
Yeah, you can't rule out something, but you always defend. You always defend the way of defend.
And that's the thing, that in medicine, how you defend. And I am sure that the examiner will agree with you.
Examiner, they'll always ask for your defense and how you approach.
Yeah. You know that your possibility should be the reference to the epidemiology. That is the first point in the science.
How you defend yourself is most important.
Epidemiology point of view, this disease is down. And therefore, it will not be in my much consideration. You can say consideration. Second point, nothing suggesting in the past at all, possible in the medicine, but may not be, I will say, in consideration. Having this argument, I will say rheumatic cannot be ruled it out, but certainly less possible. If it turns out to be, it will be a surprise to me. When you can answer in this way, I'm sure the examiner will appreciate you. Right? Yeah, you can go. I'm sure that we have taken sufficient time. You can go for the examination, because there are somebody watching us for timing also. Aditi, in my hand.
General examination, child is conscious.
Aditi, one question I don't ask, but consider, or you can write down later on. Before examination, what you are expecting in this patient? I think Janmejay and those who have not seen the patient, Shivani, that is, with such discussion, what you are expecting on the examination of the patient. I think for becoming the good clinician, master clinician, please perform this habit. That in this patient, I'm expecting this patient. Number one, Janmejay, do you expect the signs of cardiac failure in this patient? Directly, if I ask the question, so many points, but I will not be able to focus every point. But directly, if I ask the question, do you expect some points suggesting cardiac failure in this patient on examination?
No, sir.
Why not?
Why not? Yes.
Vijay is asking you this question
because you mentioned adjusted discipline and everything, and you said no. So why?
Sir,
Try to answer in the, I will say, language of Dr. Nitin. Even I also noted what sir is asking. Not just cardiac failure, I will say blanket covering. You can say signs of right-sided cardiac failure, signs of left-sided failure. Which one, if you are expecting, if at all it is, and nothing, then why?
Sir, if heart failure can present, then it is likely to be right-sided, sir. Sorry, sir, left-sided. Left-sided, sir. Sir, in left-sided cardiac failure, the signs will be wheezing, basal crepitations due to pulmonary hyperemia, and in right-sided cardiac failure.
Do you expect in our patient all these signs of cardiac, what you mentioned, do you expect that it should be there or not?
Unlikely.
I will not ask Aditi because already Aditi knows. Shivani, what will be your response? I think for that reason, before answering, ask these questions to yourself. What are the signs of cardiac failure? And then what are expected in this patient? Suppose tachycardia, tachypnea, edema, puffy face, prominent veins, neck veins, enlarged liver, right?
These are signs of what? What are the signs of what failure? Right or left?
These are the signs of right-sided failure.
Right-sided.
Left, what to see? If you want to see left, what do you expect?
What are the signs of left-sided failure?
Orthopnea, sir.
Orthopnea? Signs.
Aditi, you are right. Come on.
Sir, paroxysmal nocturnal dyspnea.
Paroxysmal nocturnal dyspnea. Maybe even the pulmonary congestion.
What are the signs you see? Tachycardia, hypertension, what you see? Pink prothysputum.
Dr. Vivek has put pink prothysputum.
Absolutely.
Good. Absolutely right. And you know what we used to say? We used to say cardiac asthma.
Start with the pulse.
Cardiac asthma. The cardiac asthma classically, that means the night time. So that in short, these are the points. Now, Janmejay, do you expect any of these points, Shivani or Janmejay? You know, this is the best exercise for learning for us. First, decide the findings.
No, sir, as mentioned earlier, that NOHA, according to NOHA grading, if it all severe, then it would have been grade 4, sir.
Okay.
Always
at least try to answer this type of the things. What you are expecting findings, what is likely growth, therefore on the growth chart, what you are expecting in this patient, then what is the likely some measurement of blood pressure, SpO2 is oxygen saturation. You know, if you try to gather that what is the expected in this patient, then examine and then see, tally whether it is in the same direction as you were thinking or different. So for different, then probably something we have missed, or something in the history or somewhere probably part is missed or link is missed. That we can establish later on. Anyway, Aditi, now you can take the general exam. This is just to sensitize you that exercise you should do. Okay.
Child is conscious, alert, oriented to time, place, and person, comfortable in sitting posture, and appears well nourished. Child has dyspnea on routine activity corresponding to NYHA class 2. The vitals are pulse rate is 96 per minute, regular rhythm and character, well palpable with normal force and tension. Respiratory rate is 22 per minute. SpO2 in right upper limb is 90.
Aditi, exam point of view, sorry for interruption. Exam point of view, somebody may ask only on the pulse, and therefore you should be fully aware in the exam. If you get the case of cardiovascular system, definition of pulse, starting from that, what is the importance of force, volume, tension? How will you clinically differentiate? Then all the peripheral pulsations. Then you should know even the various pulsations, water hammer pulse, pulsus paradoxus. These questions are going to be there, and you know that this is going to be there, then you should be prepared. Don't miss it. Please, for the lack of time, we will not go into details. You can take it further.
SpO2 in the right upper limb is 92, left upper limb is 91, right lower limb is 91, left lower limb is 92%. BP in the right blood.
My direct question, Janmejai, what is the importance of the 92, 91 SpO2? Normal or abnormal?
Sir, can be normal.
It can be. Is it normal or no?
Then the next question is going to be, what is the normal SpO2? Suppose my SpO2 comes to 92, will you call it as a normal?
Sir, less than 92 is abnormal.
Aditi, what is the cutoff point?
Sir, 95.
Absolutely, cutoff is 95. For various manifestations, okay. You know, to call it a hypoxemia, then to go for the oxygen therapy, for the development of cyanosis, there will be the different levels. But I will say you should not have agitation. This is abnormal.
Okay, Janmijay, suppose upper limb saturation is 95, lower limb is 92.
Yeah.
90.
Hey, sir, I was coming to that point, absolutely.
Janmijay.
Yes,
anyone can answer. Suppose upper limb is normal, lower limb is 91, 92.
Yeah.
Sir, maybe, due to coarctation of aorta or...
Why in the coarctation of aorta, SpO2 should affect it?
Systolic BP will be less, but why should saturation be less?
SpO2 is not going to affect it, to make the point clear, please, to save the time.
What
in coarctation of aorta, SpO2 is not going to be affected.
What is this called? Upper limb saturation, normal, lower limb.
Yeah.
What is this? What is the term?
There is blood pressure difference.
Differential cyanosis.
Yeah. So what does it? What do you imply?
Sir said upper limbs normal, pink, lower limb cynos, differential cyanosis. What condition?
Patent ductus arteriosus.
Aditi.
PDAs.
Complete the answer. Patent ductus arteriosus.
Only PDA is not the answer. PDA should not behave in this. PDA with pulmonary hypertension.
With duct reversal, flow reversal.
Flow reversal. Now, what is the reverse differential cyanosis? Upper limbs are bluish or less, I will say, lower limb are pink compared to
lower limbs are normal.
That is the reverse differential cyanosis.
Sir, it is seen in transposition of great vessels.
With
great vessels with PDA with pulmonary hypertension.
Yeah. PDA, severe pH.
Yeah.
That's it.
And one more complicated. Right upper limb normal, all the three limbs abnormal, cynos. Did you get my question? Right upper limbs SpO2 normal, all the three limbs suggesting cyanosis, and it comes in the, I will say, category of significant difference. What is that condition? Aditi, if the good scoring, my questions are going to be there, series of questions. And try to reach, I will say, good candidate should be like this. Last three questions, I say, I don't know. Then I will say, okay, you can go. Anyway, find it out. Right? Please add to this coarctation of aorta.
Preductal coarctation.
Preductal coarctation of aorta with PDA, with even the pulmonary hypertension. Then this type of complex phenomena will develop. Anyway, take it further. That's why I'm telling you, as a candidate, be prepared. What question from which exam they will come, we don't know. Dr. Nitin may be thinking something, I will be thinking in a different way, and there will be 4 or 6 examiners. So we should be prepared. And anything they can ask, not necessarily your, I will say, case. So
Yeah.
blood pressure also similarly.
Blood pressure in all
As
the four limbs.
Janmejay was telling, lower limbs support femoral pulsations are weak coarctation. But Janmejay, in one of my patients, upper limbs pulsations were feeble.
Sir, sir, Takayasu arthritis.
Yeah, it is the reverse coarctation of aorta, another name, Takayasu pulseless disease. Then I think you should. That's why I think different things you should know. And you know, this is not just for the exam. Once a while you are going to get the patient, and once a while if I don't miss it, then Aditi will get the level of the good clinician. And for that you will have to, I will say, work very hard. Please
Yes.
go ahead.
So blood pressure in all the four limbs were in 50th to 90th blood pressure centiles. This is
Lata, I think we may take 50 minutes plus. Please consider us.
Yes, sir. Sir, you can go up to 11 if you want. So no
Yeah, please,
problem from my
please.
side. It's a very good
Thank you.
discussion
Thank you.
going
We'll
on.
have to take the permission. Okay.
Okay, sir.
Aditi, go ahead.
This is the growth chart of the patient. The weight for age is between 75th to 90th
Anyway, to
centile.
save the time.
Have you completed general exam done? General?
Yeah.
Yes.
No, you not complete. Please share your screen.
Yeah. Please go ahead. I think support. Is it affected according to you?
No, sir. Child has appropriate for age growth
Okay.
parameters and normal
Okay.
nutrition.
To save the time, you can go ahead. Go for the, I will say, CBS now.
Okay.
Go only positive findings.
Sir, in the head-to-toe examination, there is grade 1 clubbing in all four fingers and toes. Otherwise, the general examination is normal.
Okay. So that means grade 1 clubbing you have noted. Right?
Yes.
That is the plus positive finding. And never mention mild conjunctival pallor. Conjunctival pallor present. Mild, no dilemma. My finding. It's pallor. That's all. Right? From exam point of view. Grade 1 clubbing, okay, we'll discuss if we get the time. So the rest of the things normal. Next. Okay, SMR not, I think not affected, right? Go to the next.
Cardiovascular examination. On inspection, the precordium was bulging. There is no
Aditi, general examination you still not completed.
Yeah. Just for lack of time I was running, but Dr. Nitin caught the point. Yes.
You just read out your general examination.
Anything?
Yeah, you said pulse, you said BP next.
Sir, pulse rate, respiratory rate, saturation, and blood pressure are the vitals.
Then.
Sir, then there is anthropometry.
Okay.
Growth. Okay. Shri Harshini is mentioning temperature CRT.
Yeah.
Okay.
No, yeah. Just share your slide.
Sir, my screen is visible.
Okay. No, it's not. Oh, yeah. This. All right. Go ahead. I think we will be running short of time.
Yeah. You can now focus on CBS. And Dr. Nitin will be very, I will say, with you because he will be the person to interpret. Sir, you can take it, please.
Yeah,
CBS.
go ahead.
Cardiovascular examination. On inspection, precordium was bulging. There is no asymmetry of chest. Apical impulse is visible in the left fifth intercostal space, displaced laterally from the midclavicular line. There are no visible pulsations noted in the neck, suprasternal, epigastric region, or back. Palpation. Apex beat is palpated in the fifth intercostal space.
Aditi, did you talk about clubbing?
Yes, sir. Grade 1 clubbing. Yes, on head-to-toe examination.
Yeah, but Aditi, better to mention in the CBS where you are describing.
Yes.
Yeah, better to mention. Yes.
You said no cyanosis but clubbing, right?
Yes.
How do you explain that?
Sir, cyanosis will be evident when the SpO2 falls below 85%, sir. But mild hypoxic conditions can
How will you
present
get
chronic
clubbing then?
mild
How will you get
hypoxic
clubbing?
conditions.
How will you get clubbing? If there is no sign, how
Sir,
will you
if
get
there
clubbing?
is chronic, yes, sir. If there is mild chronic hypoxemia, then
Can you
grade
get
1.
cyanosis? Can you get cyanosis but no clubbing? You will have cyanosis but no clubbing. That's in the first 3 months because nail beds are not formed. You'll have tetralogy, you won't have clubbing, you will have sinus. Alright? Then sinus but no clubbing. What are other causes?
That means which conditions will manifest with the cyanosis, yes, but there is no hypoxemia.
Yeah.
If I make the point clear.
Yeah, no, what I'm saying, the silent, but no, see, when early ischemic is happening, you won't have clubbing. You have to have silent for long time to get clubbing.
At least it is saying that it will take minimum 3 to 6 months to develop this clubbing.
Nail bed, yeah. Now, tell me the cause of clubbing, but no sinuses.
No, sir. But very few conditions that even within short time you may get the clubbing. Aditi, within few weeks even you may get it.
Sir,
Can you give the
infective
example?
endocarditis.
Infective endocarditis, yes. Then?
Sir, lung abscesses,
Very good, very good. You know, these are the conditions, and very rightly, Dr. I will forgot his name. He has mentioned with hemoglobinemia will be having the cyanosis.
No clubbing.
Suppose congenital variety, that will be since long, but no clubbing.
Then
that's why I said cyanosis is there, but clubbing is not there. Hypoxemia is not there. SpO2 will be normally with hemoglobinemia.
And the question of clubbing without cyanosis, we'll have, you talked of lung abscess, biliary cirrhosis of liver.
So many conditions.
There's one thing called idiopathic familial clubbing. People have without it. That's also there.
And Aditi, if you have the good performance, I will ask the one question. Which is the, I will say, site where earliest you may doubt or suspect the clubbing? Earliest. When everything is, I will say, clubbed, any person is going to say. But as a good clinician, that likely this patient is having the early stage of the clubbing and going to develop the clubbing. That means earliest which site you will look for clubbing. Or even another point, that which are the early signs of clubbing also. I think she had mentioned index finger, but madam, please, it is on the thumb. Thumb will be showing the clubbing early. And before the development of, I will say, clubbing, there is a shining and redness of the finger of the tip. Then you may get all this softening of the nail bed and the disappearance of the curvature of the angle, and then the thickening and all the gradings you will get. So I think several points on the clubbing, you may get it in the cardiovascular system, and Dr. Nitin has got the good point. So please remember, I think all the students. So now the palpation.
And there's one more thing that we say, where suppose you have a tight pulmonary stenosis, yeah? And sometimes you could have intermittent right to left shunting, which will therefore they'll be clubbing over time. But the day you examine, they may not be sinus, but they'll be clubbing long standing. So that is one of the very rare things.
Yes.
Right? So you can have sinus without clubbing. Clubbing with sinus is very rare, very few causes. All right? Okay, go ahead.
The apex beat is palpated in the fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. It is normal in character and it indicates right ventricular hypertrophy. Grade 1 left parasternal heaving is noted. Thrill is present in the
Aditi, your statement is contradicting. You say normal in character and still indicating right ventricular hypertrophy. What will be the character? I will say, what will be the character of this apex beat in right ventricular hypertrophy?
Sir, it will be heaving generally. Heaving.
Sorry?
Heaving?
Heaving, sir.
No, heaving, it will be the tapping. Heaving will be left-sided.
Tapping.
And what is the tapping? Janmejay, can you describe the exact 3 adjectives for tapping? It's a forceful. It's a sharp. It's a ill-sustained. Please remember the 3 adjectives. It's a forceful, very sharp, and ill-sustained. It does not sustain. That is
No,
the
sir. Tapping is something that touches your finger and goes back.
just
Now,
touches and goes away, touches
yeah.
and goes away.
Aditi, when you said RV, right ventricle is always diffuse apex. It's never forceful. RV is always diffuse apex.
Different. So
LV is localized.
here, if you say normal in character, indicating right ventricular hypertrophy is not, I will say, contradicting yourself. Okay, maybe with right ventricular hypertrophy with normal character, but you say normal character. The only thing you can consider, somebody asks you that why you say, you can say it going laterally only. That's why that may be support you, right? Okay.
Grade 1 left parasternal heaving is noted. Thrill is present in the
I
left.
hope you know how to demonstrate parasternal heaving.
Yes, sir.
And
On the left
how the grading?
Sir, there are 3 grades. Sir, grade 1 is it just touches the left ulnar border, and second, grade 2 is, sir, it is compressible, and grade 3 is non-compressible.
Absolutely good. Please go ahead.
Thrill is present in the left upper parasternal area corresponding to the left second intercostal space.
Right.
On percussion, the cardiac dullness is within normal limits with no significant cardiomegaly. There is no cardiac dullness beyond apex beat, hence no sign of pericardial effusion. Auscultation, child was ausculted in mitral, pulmonary, aortic, tricuspid, left parasternal area, neck and back. First heart sound is normal. Second heart sound is single. P2 is not heard. Harsh ejection systolic murmur grade 4 is noted in the left upper sternal border corresponding to the pulmonary area in the second intercostal space, and it is not radiating to the back. There are no extra cardiac murmurs or pericardial rub.
One second, let me get 2-3 things right. One, you said there is parasternal heave, right?
Yes.
Did you talk of JVP?
Sir, there was no jugular venous pulsations visible.
If you got a parasternal heave and you got a RV apex, you got a thrill in the pulmonary area, you got pulmonary, you said no JVP. How is that?
Sir, on an examination, there was no JVP.
And you said there's easy fatigability. All symptoms. This is where you get caught. This is where you get caught. Okay? You can't have that. You can say I couldn't examine water, but I don't think this is right. These are some things that are not quite drilling quite well. Have you talked of epigastric thrust? The
Yes.
11-year-old child.
Did you check for the epigastric pulsations?
No, yes, sir. There were no visible epigastric pulsations and not on palpation.
Now, what are the reasons of parasternal heave? Why do you get parasternal heave? What is the pathology?
Sir, in right ventricular hypertrophy.
Or behind right atrium, what's there? Or left atrium, dilated LA. LA and RV, these are 2 things where you get a parasternal heave.
Yes.
So is this LA, is RVH? You're sure of parasternal heave? No doubt?
Yes, sir. Yes, sir.
Parasternal. Lock kiya jaye, because you're going to be asked about that.
Sorry, sir.
I said lock kiya jaye. Because you can't go back on those words. Okay, do you think it's LA or do you think it's RV?
Sir, I think it is right ventricular hypertrophy,
Okay.
sir, because
let's see, we'll come to it later, but
sir,
see 3 things that are not gelling. You're talking about diffuse apex, fine. You're talking about parasternal heave, fine. Talk about systolic thrill in second space and PS, but no JVP. So some things are not fitting. We'll see, we'll go ahead. Now you said second sound is, how do you know it's P2 or A2?
sir,
do you know? What comes first, P2 or comes A2? What comes naturally?
Sir, A2 then.
Okay.
Sir, P2, P2, A2, sir.
You tell me what comes first. A2,
Sir,
P2, A2.
Sir, normally A2 come first and then P2.
Aditi, always the energetic will come first.
Yes, sir.
Aortic is energetic. So it will be A2 P2. It will not be the P2 A2. A2 will always be first. Right? And here you said second heard sound, P2 is not heard. Right? Okay.
It could be A2 also, no? How do you know it's A2? How are you sure it is A2? You said second out sound single, P2 not heard. You can't be, how can you be so dogmatic? Because this will get you into problems.
Or you can put it in this way, that single second heard sound is heard as a single component. But then suppose sir said, as Dr. Nitin asked you, that how will you confirm that single is due to the really A2 or P2? Suppose A2 is present, where else it can be heard? Is there any other site where even you can hear this A2 aortic component, Aditi? In other way, if I ask you, is there any second aortic area?
Sir, in the third left intercostal space.
And suppose if it is heard there, that means I can say that in the P2 what I am listening, the A2.
Yes.
When you're not sure, you can say single second heart sound, leave it at that. Exam will ask you, what do you think? Then you can say, this is what I think, but I'm not sure.
Yeah.
So you're on safer ground. Once you say, you make a dogmatic statement, you're fixed. So always say single sound, then they'll ask you what it is. All right?
That is good point, because sir suggested in the exam, be smart and presence of mind that don't invite the trouble. As far as possible, you can avoid the point unless somebody is catching you. Good. Please go ahead. Anything else is there with you?
No, sir, I have the echocardiography report.
No. We're not yet done.
Echo, I don't know. So not for me. At least Dr. Nitin can make the comment, but I think we'll discuss clinically.
And then murmurs, you got only one murmur.
Yes, sir. Only one.
Right.
Somebody, if you don't have the presentation, you can stop sharing and then discuss this differential. Or you have any summary or anything, Aditi, beyond this slide?
No.
Other systems are novel?
Okay, you can stop sharing.
Other systems novel?
Yeah, other systems.
Yes, sir. All other system examinations.
That is one thing, even the short case. Please remember, pertaining to that system in general examination, don't miss it. Even in general examination. Suppose a case of even the hepatosplenomegaly. But in general examination, pertaining to that system, we should not miss. That is very important. Similarly, I will say CVS will examine, but related other some points which are expected in other systems, we should never miss it. Now I think who will go for differential diagnosis? Aditi must be knowing everything.
One more thing, Aditi, did you talk of dysmorphic features?
Yeah.
Yes, sir,
You have mentioned?
Yes, sir. In the head-to-toe examination, there were no dysmorphic features.
Okay. One question for you.
Always in such patient mention the presence of dysmorphism. Yes.
You have to say that.
Yeah.
Either dysmorphism or stigmata associated CHD.
Yes.
Now you tell me one small question for you. Most of the I'm sure you know them better than me. Tuck, you can tell me. Tell me this dysmorphism associated with cyanotic heart disease. Most of them are acyanotic. What are the dysmorphism associated with cyanotic heart?
Sir, top.
What are dysmorphism? See, all this trisomy 21, trisomy 18, Edward, but all these things are all acyanotic.
Sir, pulmonary stenosis, Pallas physiology can present in
what are dysmorphism? What are dysmorphic features? You get something called conotruncal facies, you know? A broad philtrum, bulbous nose, thick lips, that's there. Very few are described with cyanotic heart. So that's you have to keep. This they'll ask you. Okay, now you tell me you got a saturation of 92, right?
Yes.
Saturation of 92, your paracent heap, what is the differential? What would you like to say?
I think you should first decide your findings.
Yeah.
That is very important. Always confirm your findings. And even decide that which finding I have with the dilemma, which I may not be able to explain appropriately. Always in the exam, make this clarity. Suppose with these findings of SpO2, you can say, is it normal or abnormal? Say abnormal. It is definitely abnormal, 91, 92. Second point, what does it indicate? It is hypoxemia. Anybody is going to ask you the question there. Should you consider the cyanotic? Yes or no? Janmejay.
Yes, sir.
You should consider that. Yes, it is a cyanotic. Second thing, what does it support you even? Presence of early clubbing. Depends upon the severity. Severe heart disease, I will say cyanotic heart disease will present with a cyanosis and clubbing even early age. But depends upon the severity of the heart disease. But you can say at least from the presence of these SpO2 levels and even the early clubbing, you can say that some points or evidence of the cyanosis is there. Mechanism, everything, disease, you can think later on. This should be the very clarity in our thought process in the medicine. Now, having this, I think Aditi has some problem of present connection. Her net is probably lost.
Yeah, it is not there.
Janmejay, meanwhile, you can take it. Janmejay, what will be your possibility?
Yeah, Aziz is back. Aziz is back.
Yeah, Aditi, I think Aditi must be knowing. She'll be the last person to answer. I think Janmejay also may be knowing, I know, but let him answer.
Sir,
Janmejay, you know, only answer is not going to be the fair enough. You have to explain whatever you answer.
Sir, most common cyanotic congenital heart disease variety is tetralogy of Fallot.
Okay.
And in this case, it would be mild variety.
Okay.
Not compromising much of pulmonary circulation.
What are the points favoring to say Fallot tetralogy? Even the mild variety.
Cyanotic heart disease.
Okay.
With good compensation without recurrent pulmonary infection.
Okay.
Respiratory infection.
Suppose it was there in the initially, that means in the early childhood, there was history of lower respiratory infections, classical features of some left to right shunt, and now it has presented with this cyanosis and clubbing and even exertional dyspnea. What will be your thought? What do you call it? Did you get my point? Suppose earlier it was diagnosed as VSD or PDA. Somebody informed me one day. They didn't go for the treatment. And meanwhile, gradually the child developed even the lower respiratory infections repeatedly, pneumonias or something. And now the child has presented to you with this type of the presentation of cyanosis, clubbing, exertional dyspnea. What do you call it, Aditi? Aditi,
you're muted.
Sir, Eisenmengerization.
Yeah, Eisenmenger. Do you consider that possibility in this patient?
Could this be Eisenmenger? Because she's 11 years old, grown up well.
Yes, sir. In severe case,
Okay, I want you to tell two things. If Eisenmenger, yes. If not,
yes.
Why not? If not, why not?
Whatever you answer, explain. Yes, then also explain. No, then also explain.
Okay, Aditi, you tell us why it is Eisenmenger. Jeremy, you say why it's not Eisenmenger. I mean, just interpretation.
Yes, sir.
Aditi, go ahead. Do you think it's Eisenmenger?
Sir, as the child had congenital heart disease and now the child has presented at 11 years, now the child's metabolic demand is more, sir. But still the time period is too long to, sir.
Aditi, question is going to be very, very straightforward. Do you consider the possibility of Eisenmenger complex in this patient? The way which I explained, that in early childhood or congenital heart disease was in the form of the left to right shunt. It remained unaddressed, I will say not treated, gradually went for pulmonary hypertension, and now it has presented to you with the cyanotic component and you are diagnosed even again with a complex. Do you consider this possibility in your patient? Yes or no?
Sir, it is less likely in this patient because the child's age is
Explain
11
it. Why? Why? Suppose not considerable, then also why? If you consider, then also explain.
Sir, because the child's age is 11 years and Eisenmengerization, sir, it does not take this long to
Why
for
not?
the reversal option.
Wait.
You know, immediately sir also said, wait, and I'm also asking the question, why not? Yes. Suppose simple, it was the PDA or VSD. These are the two common large, I will say, left to right shunts. Nowadays, we don't get this type of this problem, I will say, patients. We used to get it in our, I will say, learning. That there was no facility, even no treatment was available. They will not go for farther places like Mumbai. They will remain untreated. And we used to see this patient 10, 11, 15 years with this type of the reversal of shunt and in the cyanosis, clubbing, everything. But you know, in that type of the case, what will be the story? Does it help? Does it suggest in your patient? Yes or no? So what if I, to make you clarity and to even some thoughts, I will say I don't consider the possibility. I'm helping you. Why not?
Sir, the child's growth is normal. Usually,
you know, several points, Aditi, you can make in this way. That left to right shunt, we are expecting some manifestations in early childhood in the form of at least some complications, lower respiratory tract infections like pneumonias. Number one, which you said in this patient, negative history is not there at all. Second point, if the congenital heart disease is such a way now going for reversal, that condition is not allowing the child to grow. Growth is going to be affected. Weight and height is not going to be normal the way which you have shown on the growth chart. So that is out of question. It is not going to allow the child to grow. So you can say, but still suppose if it is the cyanosis and clubbing is there, then which kind of heart disease you will consider? Janmej said fellows with mild variety. Which mild variety? That also you should know.
One more, anything in your examination which tells you it's not Eisenmenger.
Yeah.
Examination. What if an examination?
So many things are there. Yes, sorry asking, but even on examination, cardiovascular system, particularly what you are going to get it. P2 will be loud. On the contrary, here you said P2 is not even, you don't appreciate. It is quite against the finding also. So P2, on the contrary, P2
and what about your murmur?
Murmur. What about the murmur?
Yes, sir, the murmur is palpable in the pulmonary, is heard in the pulmonary area.
What is the grade? What is the grade of the murmur?
Sir, it is grade 4. So the murmur is large enough. It is not very severe.
Aditi, my question. Compared to the early childhood, murmur grade is going to increase or decrease? Suppose it's systolic murmur. It was VSD or PDA, systolic murmur. That was grade, suppose 4 or grade 4 in the past. Now it has come to grade 2 or 3. It is good thing or bad thing? It's a complication. On the contrary, grade is going to decrease. P2 is going to be loud, right? Even the pulmonary congestion is going to decrease. Cyanosis is going to increase. Hypoxemia is going to persist on. Child is not going to grow.
You never get a grade 4 murmur. Grade 4 murmur is out of question.
Grade 4 murmur is out of this complex.
What is the grading of murmur? Grading of murmurs? 1, 2, 1 is counter. 2, 3. What is 2?
Sir, grade 2 is it is audible in a quiet room. Grade 3 is loud but no thrill. Grade 4 is loud with thrill present. Grade 5 is it is audible with stethoscope just on the chest, and grade
no, not
6
just 5 is grade at an angle of 30 degrees.
You have to be very specific.
In the lighter mood, I will say grade 1. What is another name of grade 1, Aditi? Murmur grade 1. Professor Murmur. That only professor should get it, provided professor is of that level. The point is very soft, easily missed. Right. Anyway, I think good. So here, the Aditi, now what is your possibility? Janmeja has kept its possibility.
Sir, there is on examination, there is right ventricular hypertrophy and there is pulmonary stenosis findings, sir, because there is this left second intercostal space grade 4 ejection systolic murmur. So right RVH with pulmonary stenosis, but there is no evident cyanosis. So I consider it as, sir, this is a cyanotic congenital heart disease, but very mild variety, sir, with good pulmonary collaterals.
Mild variety means which lesion is mild? In Fallow's cytology, which lesion is mild? Which one?
Pulmonary stenosis.
Yeah. Simple answer should be right ventricular outflow tract obstruction, because it can be anywhere. It can be valvular, it can be infundibular, it can be supravalvular, it can be pulmonary artery stenosis, anywhere. Therefore, but the point is, whatever the right ventricular outflow obstruction is there, which you mind, murmur is due to what in this patient? Suppose Fallow's cytology, murmur is due to what?
Sir, it is due to RVOT, right ventricular obstruction.
Sorry?
Sir, it is due to RVOT, pulmonary stenosis.
Pulmonary stenosis, not
VSD.
Not VSD.
Why?
Sir, it is usually large VSD, sir, bidirectional.
Large, malaligned, unrestricted VSD. However, there's one variety. Do you know? You can have restricted VSD as well.
Anyway, I think lot many things.
One thing, Aditi. So you think it's a tetralogy?
Sir, it is possible.
What is your something in your finding that's against tetralogy? In your CVS findings against tetralogy? Against tetralogy. You said the parasternal heave.
Left parasternal, yes.
What does parasternal heave indicate? What is the implication? What does parasternal heave indicate is a RVS, pulmonary stenosis, right? But what does it indicate? It means the interventricular septum is intact. But tetralogy, you have a large VSD. Therefore, TF, you'll never get a PSH. Because all the blood is shunted across the LV. So you'll never get. So parasternal heave means intact septum. Always.
I think Aditi, exam point of view, now few questions or for you even to keep in mind, because difficult to now already we have crossed lot. I will say we are quite late compared to our allotted time, but we'll take few minutes. You know, suppose fellows or these are going to be the very common patients in the exam, and then you should know the details of embryogenesis and every aspect. So somebody is going to, what is the Fallow's tetrad? That components you should know. Somebody is going to ask, like in this patient, that what is the pink Fallow's and what happens so that at least the cyanosis does not develop. Third, even people say, what is this pentology of Fallow's or something? Dialogy of even the Fallow's or triology of Fallow's. But the basic question which I want to ask you or yourself, Janmeja, anybody can ask, what is the basic reason? Or I will say only suppose single embryological problem if I have to explain, what is the basic structural problem with this patient?
You should term this as monology of Fallow.
Monology of Fallows. It is the monology. That means basic problem is only one. Then with a different variety, different gradings, and then you get the different varieties. But what is the basic embryological structural problem with this type of the condition?
Endocardial cushion defect.
What happens? It is Janmeja, I think hurried you answer. Endocardial cushion defect comes in the interatrial septum.
Sri Harshini, you have to expand. Sri Harshini, you have said it, but Sri Harshini has to
Yes,
expand.
I think Dr. Sri Harshini had mentioned, basically you remember the embryology, that there is initially basic one structure, truncus, what we say. Then with the septum, it is divided in two. Anterior develop the pulmonary component, posterior develop this aortic. This septum problem is basically the basic lesion. And due to its deviation of the septum leads to the different varieties.
Yes, posterior deviation. Yeah.
Varieties of even the obstruction, narrowing, and even this VSD component leading to the whole manifestation of these fellows. But the problem with the deviation of the septum, which is dividing this truncus in the pulmonary and aorta. So if it is there, it will be parosteatology. But suppose overriding of aorta, what we say, if it still increases, that is the transposition of great vessels. And suppose that septum is divided lower part, but upper one, that is the truncus arteriosus. So as a whole, if you see, these are depends upon the structural severity, different lesions, phenotypically we answer. But embryologically, structural lesion is the same. That's the thing. I think anyway, Aditi she can answer the echo findings. Sir, Dr. Nitin, let us learn what they have got in echo. Then then we'll end. Aditi, I think her connection is again lost.
Otherwise, if you go on, Gurukul will never call us again if you go on beyond 11.
Janmete, what was the echo report? If you have the idea?
No, sir.
No idea? Oh, I
no
thought
idea.
You may be knowing. Anyway.
Okay, till Aditi comes back, anyone can answer. Jan Vijay, Sri Harshini, anyone can answer. Tell me the relation between the murmur and cyanosis and severity of TOF, mild, moderate, severe.
If murmur gets lower, then the severity will be more, sir. It just severe stenosis.
Severe stenosis, then murmur is what?
Yeah.
Lower.
Then what happens to the cyanosis?
Absence of murmurs.
And then cyanosis?
Cyanosis more, sir. Will be more.
Worsens. So the worse is the cyanosis, the less is the murmur, and the more is the stenosis.
Aditi, we were waiting for you. What is your echo report? Just for our learning. Just you can answer orally. We don't want anyway.
Yeah. Severe of sinus should not be lower. It should be severe of sinus. Yeah. Aditi, what's the report?
TOF, sir, it is TOF, tarbotic obstruction with good pulmonary collaterals, fair confluent branches of pulmonary.
Aditi, that your slide is not seen. Echo slide is not seen. Okay, so what they are doing? TOF
with confluent fair size branch pulmonary arteries with normal biventricular functions.
Okay, can you stop sharing now? I think already we have overshooted so much. Just I will say last history part and we'll end over here. Blalock and tossing operation, we know that shunt in fellows. Just for I will say history point of view, Blalock was surgeon, tossing was pediatrician. Cardiologist. They were working together. In those days, I think few years back, both of them died.
Yeah.
They were working together, and then tossing pediatric cardiologist asked her colleague. Tossing pediatrician was she, and Blalock he.
Helen Tossing, Alfred Blalock.
Yeah, Alfred Blalock. So what even suggested this cardiologist that blue babies are dying because blood is not reaching to the lungs. So she suggested that can you do something, some surgery, some shunt, so that you can divert the blood to the lungs. That was the talk between these two. Then Blalock said, yes, good idea. Give me some time. I will think, and in a short time, Blalock devised the shunt, the anastomosis between the subclavian and the pulmonary artery. And then they observed that, yes, now the babies are surviving. That the story, I will say, they opened the doors for this, I will say, cardiac malformation. Then lot many development has taken place in this modern time. And now these babies, even the neonatal period, they are operating, surviving, doing the very good. And I'm sure that from the Dr. Nitin and his term in the future, we learn on this aspect also. Just to wanted to convey to our friends that this is the part of the development. And you know that the brain, how she, and this tossing she was having, if you read, I think you will get on Google and everywhere. Her health point of view having so many limitations to her.
Yeah.
Still, she contributed a lot. And then we learned that, oh, fortunately, God has kept us intact.
Yeah.
We should contribute something. That's
So-
the moral of the story.
So, you know, one very interesting point is they had a technician called Thomas. Now it's called as BTT shunt. It's not it's called BTT shunt.
Yeah.
Because they had a technician, his name was Vivian Thomas, and he was a black, so he was not recognized.
Yeah.
Now, so now it's called BTT. His work was more than Alfred Blalock. Now it's called BTT shunt. That's history.
I think
Yeah.
besides the clinical medicine, the history is also interesting.
Yeah,
Those who are really interested. Every time we'll keep these types of glimpses from the history also.
Yeah.
Sorry, I will say first we should say to the office bearers, the whole team, they allowed us.
They
We
allowed us,
shooted
yeah.
a lot. But really, Aditi, selection of case was fantastic. You came with good preparations. You didn't, I will say, ask your friends to remain present, and you fight, I will say, alone with both of us and so many even people. And very, very rightly, I will say, you tried to justify, give the good explanations, and I think you are well prepared for your exam. All the best, and you have done the good job. At least I should appreciate your mentor, Dr. Vrajna, Dr. Preeti, and naturally, they also help you a lot for preparation. And I'm sure that Dr. Nitin, his presence made us, I will say, difference in our discussion and learning, and the whole team. We understand that this, I'm learning from the group discussion, how much early they start even contacting each other, asking who is the presenter, which institution, did you talk, whether person is ready. And you know, they are, I will say, taking lot many efforts. To be very frank, we should never forget the whole team. Under the leadership of Dr. Nehal Ben, Madam Jhankhana Ben, Dr. Lata, Yogesh, we have a top person, I will say, and the whole team. Really taking so much pain. And to be very frank, they work very hard. Therefore, for 2 hours, we learn a lot. Thank you very much to all of
Thank you, sir.
And again, sorry for taking, probably we have taken the liberty to overshoot. This was probably some interesting discussion, and we learned a lot. I'm sure others must have learned because we learned a lot.
Yeah.
Thank you very much.
Thank you, students, for interaction also. Also, yeah. Thank you, sir.
So thank you, all of you, and good night.
Good night, sir.
Over to you, Dr. Lata, and your team.
Thank you so much, sir. Thank you, Nitin, sir. He is always there whenever I contact him, and he is always one step away only. So thank you for agreeing to being an expert. Baldev sir is always there to guide us for each and every case. Thank you, Jhankhana ma'am. Even though she was busy for another meeting, she joined as soon as she got free. Thank you, Sandeep bhai. Again, a busy person, but never leaves e-Gurukul alone. And thank you, Lata, for coordinating so well. Thank you, Aditi. Already, sir has said it's a very, very beautiful, wonderful presentation. And thank you, all the other students, to be there and joining the discussion.
Let me specifically appreciate Janmajay for good support.
Yes, Janmajay and Aditi both.
And let me announce one thing. Dr. Baldev sir, just we remember you in meeting. There is a PG PG classes by Indian Academy of Pediatric. We are going to started one program for
Very
3
good.
to 5 days physical program for the exam going student only, and
Hello.
this is in the pipeline, and shortly we introduce that program for the PG students, and some memorandum is given to the PG student also for the attending these programs, and this program is going to journal programs, and Baldev sir is also one of the team member of that. But I told sir is busy with the e-curricle, so sir is not joined. Sir was not joining today, and in next time he will definitely join. And all the top stalwart is there, and all the examiners and teaching academician are there, and they are going to make the module for the PG student for the physical examination with the case presentation, and all that part are including in that, and within shortly we introduce that module for the PG student, and zone wise that they decided the medical college where the student exam going particular exam going student are
Right.
may presence and give the physical training to that things.
Actually, our President Dr. Nilam Mohan called me in 7:30
Yes.
today.
Yes, sir.
And I told Madam that yes,
Yeah.
you can go ahead. Already we have committed. So at the same time, parallel, this schedule of this program is there. And Dr.
Okay.
Subara was also there. He's very close friend of. I said, sir, I will not be able to remain present in this program. And but I'm sure that whenever this learning is there, teaching is going on, I request even not only to the student, the teachers also, please never miss it. And that's the only thing which keep us, I will say, updated in the subject. So Sandeep, whenever you say whatever the topic, whatever the place,
Yes,
I will try to reach. I will be there.
yes, sir. All India we are decided, and them the team is the ready, and same team teaching same subject to the all the students. So no differentiation and differential view of academician
Teachers.
to the student, and not confusing to the student, sir. So I left in between that for because 9:30 to 10:30, 11 o'clock there is a meeting of this,
Right.
and after completing this I will join again
Okay.
Gurukul, sir. Yeah.
Yes.
Thank you very much, sir.
Thank you for this details of information. Thank you. And good
Yeah.
night to all of you.
Okay.
Because of all
Night,
PG students are there, so I will inform all the students because they yes, sir. Take advantage of that, sir.
Right.
Thank you.
Yes, it's a very nice initiative, sir.
Yeah.
Really.
Okay.
Thank you.
Thank you.
Thank you, sir. Thank
Good
you,
night, sir.
everyone.
Good night.
Good night.
Good night, Nitin, sir. And
Good night, ma'am.
Good
Nice to see you.
Nehal madam, Lata madam,
Yeah.
Baldev sir.
Good night, sir.
Good night, sir.
Good night.
Okay.
Good night.
Thank you.
Okay, thank you.